Ask, why do we do this every year? And the reason is that Mike died 27 years ago, and I still miss him. I mean, he was that great of a human being, excellent physician, fantastic GI partner. It was just, he was amazing. He came to us from LA Children's, who at the time had some attendings named Frank Sinatra and Danny Thomas. Not lying, LA. Anyway, and it was our gain, their loss when he came here. And he was just a breath of fresh air. He was just wonderful. I used to go, my husband and I used to go on vacations with him. We went to Florida for a week. We did ski vacations. He lived in downtown Phoenix. He would phone us and we would go to like plays with him. And Jim and I were much more cultured at that time than we, are now, because he took us to all these places and everybody loved him. The patients loved him. The families loved him. The nurses loved him. He was a fantastic partner. The staff loved him, everybody. And it was like he and I were so similar. Like we had the same, we talk about patients, we talk about other stuff. We both realized that it's crazy that people want to get up early in the morning and start working instead of sleeping in. I mean, he and I were so in sync on so many things. We were just he was like my gay soulmate. But one difference, he was super popular. Everybody loved him. Me, not so much, but he was super popular. Anyway, so he and I did a clinic in the East Valley, and we did it from noon to 9 p.m. and it was perfect. We got to sleep in like normal people, go to the clinic, see patients, be awake and alert, and then go home and have a nice evening. And that clinic from 5 to 9 p.m. was the most popular clinic because parents didn't have to miss work and children, high school students didn't have to miss school. So that was booked and nobody ever no-showed for that clinic. So it was great. So anyway, I went to San Diego for CME for a week, and I didn't even know he got sick. He came to work, he was jaundiced, he's still on the inpatient service, still working. Then he goes into the hospital and he has this high bilirubin, but they find gallstones. So he calls our secretary, Joyce, on Thursday, and he says, they found gallstones, I'm going to have a lap chole, I'll be fine. Don't cancel my patients for Monday, okay? Saturday, he goes into acute fulminant liver failure and dies. I'm in San Diego. This is 27 years ago. No texting, no cell phones, no internet. I have no idea what's happened. And I get home Saturday after midnight, and there's all these calls on my caller ID. There's no voice message. There's just all these phone calls. And I'm like, oh no, one of my patients is probably dying in the hospital or something. So it's after midnight. I'm not gonna call people. So Mitchell Sheb calls me Sunday morning. He wakes me up and he's like, Mike is dead. No preamble, and I just went into shock. I was devastated. It was horrendous. And the next day I had to do my clinic in the East Valley and see his patients and tell them that he had died. So Jim drove me to work because he didn't feel I was mentally prepared to drive to the East Valley, so far away from Phoenix, of course. So he drove me there. And I had to see Mike's patients. So and you can't just, the patients were crying, the families were crying, the nurses were crying. It was horrendous. Instead of ending at 9, that whole thing went to like midnight. And I know because my husband had to come back and pick me up. And, you can't just walk in the room and tell someone their favorite doctor died and then leave. It's not like on TV where the doctor walks in and says, your child has a brain tumor. It's inoperable. See you later. And they leave the room. So, we had to spend all this time with them. But anyway, that's why we have this memorial, because we still remember him but I can tell you this, if Mike is in heaven looking down on us, he's still asleep. He's not awake yet. He's going to catch this on video, okay? He's going to catch this on video. Probably video recordings work better in heaven. Maybe IT works there. That is what heaven is all that works. I don't know. So he'll be watching this later, but I'll leave you with these 2 thoughts. One, he touched my life deeply. You never know how deeply you touch some people's lives. And as physicians, you will touch your patients' lives deeply. So try to make it a good thing, not a bad thing, the way you touch their lives. And secondly, life is short. He was my age. He was suddenly dead, young man. Life is short. Life is not a dress rehearsal. Live every day, make every day count, and just be happy. We're all lucky to be alive.
Thank you, Crystal. Thanks. And like Christy said, it was obviously through a generous gift from the family that supports this invited lectureship. And we've had great speakers here throughout the years, and it's my pleasure today to announce another one. Dr. Rohit Kohli is the division chief of pediatric gastroenterology, hepatology, and nutrition at the Children's Hospital of Los Angeles. He also wears several additional hats. He's the associate director for the Sabin Research Institute. He is associate chair in liver and intestinal research, and he is a professor of pediatrics at the Keck School of Medicine, which is affiliated with USC. It's a real pleasure for me to have Rohit here. Rohit and I, this makes maybe us look old, I guess, but we were both in fellowship in 2003 to 2006. So we were, and as many of you know, you get to know your classes of fellows well. But it's been a real pleasure for me to see Rohit's success. He moved, now you said 8 years ago, right, to CHLA, and has just grown and really expanded that group both on its clinical and research presence. And his particular interest is in obesity and the role of bile acids that play in the development of NAFLD and now I know it keeps changing its name, but metabolic associated steatohepatitis. And so I certainly will not be able to give this talk. So hopefully he'll come back. But he, like I said, he's been really, really great in doing that. He has been involved in that research for now many years and really is at the forefront of doing obesity work. Additionally, I've been able to cross paths with him at our national society, NASPGHAN, at our national, in our advocacy committee. And so we've actually gone to Washington, D.C. together and advocated on the behalf of children with pediatric GI-related illnesses. So I will now turn it over to you, okay? Okay, perfect. I think, oh yeah, perfect. Okay.
Are you telling me he's taller than I am?
Oh, sure.
Thank you so much, Ashish. It's a real privilege to be here today to honor Dr. Shelton and his memory. I was told that Dr. Ingabo mentioned that he actually used to be at Children's Los Angeles as well, so even a stronger feeling. I always say a lot of individuals who've met me before, I say relationships are everything. Ashish and I have climbed Camelback before he was ever here together, and looks like Dr. Shelton left a strong memory here as well. So having said that, let's dive a little bit into, we have to click here. All right, into the world of pediatric liver disease. I hope I leave with at least one of you a little bit more interested in hepatology than when I came here. These are a few of my companies disclosures that I will not be talking directly about anything from Epigen, but I will mention two drugs, both FDA approved now, one from Mirum and one from Albireo, and nothing from Sanofi. So what about the liver, right? This inquisitiveness that we have in us when we're born needs to remain there. This is one thought that I feel like this picture, at least to me, speaks to. And this other picture speaks something else to me. Of course, we know that overeating, malnutrition on the extreme of taking in too many calories is what has led us to the obesity epidemic. But for me, this picture speaks to a couple of things more, which is the lady in the background has her eyes on the gentleman's burger while she has the same exact burger in her hands. So I stole this picture about 20 years ago from my mentor at that point, Randy Seeley, and I've used it in almost every talk I have since then. So John, that's why it's still 1997 circa the formatting of the PowerPoint. So obesity, how do you approach it? We all understand this. This is not rocket science. You don't need Elon Musk here. Lifestyle are the bookends for the management of obesity. Within lifestyle, of course, there's a D and an E, diet and exercise. And if there's time at the end, I can debate with someone where diet is much more important than the exercise portion. But in the middle of that, there are certain individuals who will probably benefit from surgical or actual pharmaceutical interventions. But do we really need to worry about fatty liver disease? And we can go over the nosology at some other point in children. If you look at a recent paper from the San Diego group, Jeff Schumer leads the group there that studies fatty liver disease. He collaborated with Kaiser Permanente, Southern California. They have a very nice cohort, right? Kaiser is an enclosed system, a closed system. So they follow the same children for years and years because of the insurance situation. And they saw from 2009, where their incidence of, at that time called NAFLD, now called metabolic dysfunction associated steatotic liver disease, MASLD, 36 in 2009 to 58 by the same definitions, by the same group of people following the same cohort. So it's almost doubled in incidence in Southern California. You can extrapolate that probably to the rest of the US at least, if not the rest of the world. The American Academy of Pediatrics has obviously taken this seriously for decades, but the most recent iteration of the obesity guidelines took it a step further. There's a lot of controversy, and I won't delve into too much of the controversy, but you can make sense of it yourself on the next slide. When you look at the components of treatment for obesity, there's overweight in the middle, and there's obesity on the right-hand side. And you can see age groups, less than 6, 6 to 11, and 12 plus. And the left first column, there's MI, motivational interviewing, not myocardial infarction, intensive health, behavioral lifestyle, the D and the E, pharmacotherapy and surgery, the same paradigms that I depicted on that cartoon. What has changed in 2023 is that they said, consider pharmacotherapy and surgery early. Don't wait. That caused a lot of buzz. And again, I'm not going to go into the details of it, but just to set the stage that even the AAP is now putting money into surgeons. So all of us in institutions have some form of a weight management clinic. We have 2 at CHLA. The problem with weight management clinics that focus on diet and exercise we'll go over in a second. And then that will lead me to why I led a kind of a 20-year journey trying to understand the surgical treatments of obesity. So weight loss interventions, we said lifestyle, you will get weight loss. The unfortunate part of weight loss, which a lot of us, our friends and family, if not ourselves, have seen, is that when you lose weight, you regain weight. There's this tick mark sign that we're left with, despite our best efforts. You add drug therapy, even the more recent ones, Wegovy and Ozempic and all the GLP-1s and GIPs. This is factored in with orlistat, an older version. You'll get weight loss, but again, when you stop the drug, it'll get a tick mark sign. When you do bariatric surgery or weight loss surgery, the difference is that you have to shift the y-axis to 40% weight loss. And the other difference is that there's a maintenance of that weight loss over a long period of time. This is 15-year follow-up data, adult, but 15-year follow-up data. So why not study something that actually works, right? And not just works. Over the years, I've changed this slide from having 1,000 surgeries a year to 1,200 to 1,500 to 1,800. Now, my latest information is that about 2,000 of these surgeries are being done, sleeve gastrectomy or Roux-en-Y gastric bypass in certain instances, for adolescents in the US. And this is again from more insurance data. Despite that strong success rate, only less than 1% of eligible patients are getting said surgery. Insurance companies were denying all of them all the time. Why? Anybody's guess, but my guess is that if you have Anthem today, you may have United tomorrow and Medicaid day after. So why should Anthem pay for success or betterment of Medicaid? That's the bottom line, in my opinion. So they were not paying for it. More recently, since the GLP-1s have come on, they don't want to pay for them for life, $1,500 a month. oh, maybe we should pay for the bariatric surgery. So there's a shift happening, which we'll all watch in front of us. But that's not what we're going to discuss here today. We want to talk about children and why obesity clearly is a problem and what we can do about it. If children are having bariatric surgery, that cannot be the solution. If the insurance companies say yes or no or, not, or so forth, there has to be a better way to treat said liver disease, which is, of course, steatohepatitis. When you convert from having just increased fat content in the liver to actually having fibrosis and inflammation, what we used to call NASH or non-alcoholic steatohepatitis, and what we call today MASH, which is, again, metabolic dysfunction associated steatohepatitis. Even I'm still learning about it. All right, so MASL to MASH. When you have MASLs, if you don't look at liver biopsies all day long, this was a child that I saw in Cincinnati Children's when I was a younger faculty member in 2009. You can see all the white vacuoles shouldn't be there. They should be pink homogeneous hepatocytes. Unfortunately, this child had pan-lobular, all of the zones, zone 1, 2, 3, the whole lobule is, all the hepatocytes are filled with fat. And when that happens, that's fatty liver disease or MASLD or NAFLD, whatever you want to call it. What's colored in blue and highlighted by that arrow saying stage 1C is collagen, which is deposition of fibers in response to the fat that being deposited. When you have fat in excess of 5% in the liver, that is the definition of having fatty liver disease. However, not everybody will respond the same way. You can have a house guest that you get along with. And then there are certain ethnicities such as Asian descent or Hispanic descent, certain genetic phenotypes like PNPLA3, when you will not get along with the house guest, the fat vacuole, and you will develop inflammatory responses, and then that will lead to fibrosis. So this child already at 10 years of age did not get along with the fat, and there was scarring developing. Was lost to follow-up for a couple of years, came back and again had elevated liver enzymes. Now he had much thicker bundles of scar tissue. And you can see almost a nodule forming here. So there was a debate between a couple of our hepatologists at Cincinnati whether this is already cirrhosis. And they decided not to call it stage 4, which would be equal to cirrhosis, because they said, we cannot call cirrhosis on liver biopsy. We can say it's stage 3 to 4, and we'll leave it at that. That's a radiological diagnosis. But at 12 years of age, with no other hepatic comorbidity, just being overweight, obese, this child has such bad liver disease. So yes, it exists. And what worked to reverse that obesity was bariatric surgery. So Dr. Seeley and I bantered about quite a bit. What are the probable mechanisms for the success of bariatric surgery? People used to talk about restriction. You make the stomach smaller. Malabsorption, you're roto-rootering the intestines, so there will be diarrhea, there will be loss of vitamins and fat and so forth. That was really not our idea. We thought, let's think about the different signaling that's happening after the surgeries happen. What about energy expenditure? What about satiety? What about satiation? So I was at one of our GI meetings called DDW, which is coming around the corner. And when we sit in the audience, sometimes at these big meetings, you start to have some thoughts. That's a good thing, right? So I was sitting in this meeting and Dr. Sam Klein, who's the senior author on this paper, was presenting his group's data from WashU in St. Louis, comparing Roux-en-Y gastric bypass, which is kind of the gold standard bariatric procedure, to lap bands. How many of you remember what lap bands are? Laparoscopic adjustable gastric bands. They're no longer in use, and the reason they're not used is they didn't work. However, you can always find a small cohort, small percentage of them that would work. And what Dr. Klein's group did, David was the lead for that paper, it came out in JCI. They found a group of Roux-en-Y gastric bypass patients and matched them to weight loss, paired them to patients who had lap band and had equal amounts of weight loss. So this is a graph that he had showed there, that we had these metabolically equivalent patients in both of the groups, Roux-en-Y versus lap band. So I walked up to him and I said, Dr. Klein, do you have any samples left over from the study you just finished? because I'm interested in bile acids. And I think that they might be a signal to the success of these surgeries. And he said, sure, we're going to throw them out anyways. You can have them. So we looked at bile acids. And what we saw was that in the Roux-en-Y gastric bypass, which of course we still are doing, there was an increase before and after surgery in circulating serum bile acids. Any residents, fellows in the room? All right, what's the difference between bile acids and bilirubin? Anyone? Which one's a byproduct, a waste product, and which one's actually something we need? Bilirubin is a waste product, right? You break down heme and you produce bilirubin. Bile acids actually are manufactured out of the substrate cholesterol, so we need them. So there has to be a reason why bile acids are rising in Roux-en-Y gastric bypass patients, and they were not so in lab band. Lab band, they were decreasing. So why not just give bile acids if that's a signal, Rohit, that's going on behind the scenes? And by the way, Rohit was not the one that came up with it. Sam Klein had already published in Diabetes a few years before. He had given toroursodeoxycholic acid, or TUDCA, which is a bile acid, to improve liver and muscle insulin sensitivity. So we said, okay, let's try this out for weight loss, right? We put in obese rats, we put in a pump behind their backs, which delivered directly to their jejunum through a pipe bile acids, TUDCA, the same that what Dr. Klein's group had done in humans. And what we saw was that you would go down, surgical insult, so forth, even with the vehicle, but then stabilize your weight loss. However, with 1 mg per kg or 2 mg per kg of TUDCA, toroursodeoxycholic acid, you got sustained weight loss after surgery. The problem is that this can't be the answer, because at that dose, you get diarrhea. You have too much bile acid in your system, and everything's pooping. So that's not going to be the solution. However, can there be mimetics? Can there be molecules that you can target which are being of receptors that are being targeted by bile acids in that signaling cascade? So actually, the NIH thought the same way, and there was an adult trial called Flint. We had dinner at Flint yesterday night, different Flint, which targets a bile acid nuclear receptor called FXR, or farnesoid X receptor, and the molecule they used was obeticholic acid, which is again a bile acid. And again, an adult study, what they found was that they actually made a difference. Obeticholic acid improved histological features of NASH. It reversed fibrosis. But, and this is, any economic majors here? No one did economics when they're undergrads? Right. Anybody interested in the stock market? So the day that these data were made public by the company that made obeticholic acid and was partnering with the NIH, they made a press release, and the stock went through the roof. You can imagine, this is the first drug that's going to come out that's going to cure this disease that is for millions of people. They didn't mention a small thing, this but that I have up there. There were some safety issues. There was a drop in HDL and a high increased LDL and total cholesterol. Again, going back to basic biology, if I stop production of bile acids by giving exogenous bile acids, what substrate is going to accumulate? Cholesterol. So when the NIH found out that the company put out the press release and the stock went through the roof without talking about the side effects, they threw a hissy fit. And they had to do an addendum to their price, to their press release, and the price tanked. So the very same day, they had an upswing and a downswing. Whoever made money out of that, I don't know. But the drug has never come back for NASH. We have a long list of drugs that are being studied. I'm not going to talk about all of them. I am going to talk a little bit about the ones that I'm interested in. I feel I have a little bit of knowledge about, which are the bile acids. When we just talked about FXR and obeticholic acid, we're going to talk about ASBT, which is the apical sodium bile acid transporter that allows the reuptake of bile acids every time we eat. We circulate bile, but we don't use up all of it. We pretty much 95% of the unused bile is taken up through the ileum, through these receptors called ASBT, and back recirculated in an enterohepatic fashion. There's some downstream signaling called FGF19 and 21 of that reuptake of bile acids we'll talk about. And we just had a month ago a new approved drug, finally the first FDA approved drug for MASH, thyroid beta agonist, which I will mention next. So this is the new drug that's come out. It's called resmetirom. It came because they had a very successful phase 3 randomized placebo-controlled trial in NASH in adults with liver fibrosis. And what you see here in this adult study is that if you walk from left to right, individuals who had no worsening of fibrosis but NASH resolution, the pale blue is placebo, 80 milligrams of resmetirom or 100 milligrams of resmetirom in the light or dark purple. And you can see a very nice step-up effect with the dose. For fibrosis improvement with greater than 1 stage and no worsening of the activity score for NAFLD, there was not much difference between the 80 and the 100 milligrams. But suffice it to say, this was strong data in a large enough study that the FDA just approved it back in March. I said I'll talk about a few other drugs. FGF19, this is again another adult study, also showing fibrosis improvement with no worsening of NASH, placebo versus FGF19 analog called aldafermin. FGF21, we had looked at it in adolescents who had weight loss surgery, and we had seen a very nice R-square of 0.82 between the amount of weight lost after surgery with FGF21 levels. FGF21, for those who are keeping score at home, is also known as the hunger hormone. It kind of is the yin and yang between FGF19 and FGF21. Again, FGF21 has been studied in adults and shown to produce an improvement in NASH fibrosis. So repeatedly, this signaling pathway that starts with the deposit of food, released bile, signaling through bile acids, taken up through ASBT, going through these FGF19 and 21 mechanisms, seems to be reoccurring and influential in changing the tone of fibrosis within the liver. People have started to look at combination therapies as well. Here you have a study which is preclinical, where an ASBT inhibitor, remember ASBT being the bile acid transporter, you block the ASBT recirculating process for bile acids, add FGF15, which is the analog in mice for 19, and you start to see reversal of fibrosis. This is a very detailed map of all the possible, at that time known in 2015, and there's more that's been added since, that Dr. Setchell, who was one of my mentors back in Cincinnati, thought we should be studying, and we continue to study for NASH resolution. Again, understanding that one procedure that works. So I'm going to summarize here this portion of the talk where bariatric procedures increase serum GLP-1. I didn't go into the data, but take my word for it, and of course, take the successful drugs that are out there for it. And bile acid levels, right? There is an increase in the successful bariatric procedures of serum bile acids, and they're linked. Bile acids lead to GLP-1 secretion. GLP-1s can produce weight loss. Bile acid triggered pathways, FGF19, 21, FXR, are important for the liver benefits post-sleeve gastrectomy. And maybe in the long run, we'll be thinking about combination therapies instead of individual therapies. So I'll take a break here and shift gears. Now that we've understood that there is liver disease in children, maybe let's tackle a little bit more nuanced issue, which is not affecting a fifth of the population, which is liver transplants. Do they really need this topic to be discussed in pediatrics? The Washington Post thinks, though, they say that fatty liver disease is the fastest growing reason for transplant in young US adults. I believe, Ashish, you invited Naeem a few months ago or weeks ago. This is his paper that got noted by the Washington Post from about 5 years ago. And then, of course, we have the pediatricians in the house. And this is the laundry list of diseases that we transplant children for. More than 50% of any World Series you'll see, not baseball, what World Series of published reasons for transplant in children, biliary atresia is going to be more than 50%. In the US, we do about 600 liver transplants for children every year. This has been static, 550 to 600 for the last 2 decades. Hasn't changed. It's a good thing. Our survival rates have been going up. This is just data from Children's Los Angeles. We do about 30, 35 transplants a year. This is dated, celebrating the 400th transplant. We've done 500 plus now. Long-term survival, talking about memories and relationships. This is a picture from 1998. You can see a baby in arms here. This is Dr. Danny Thomas that Dr. Ingebo just mentioned. He was the physician in collaboration with Dr. Yuri Ginnick, our surgeon that started the program back in '98. That baby in arms is standing right here in 2016. She has grown into a tall, beautiful young lady, and Dr. Thomas is a little bit older in this picture. And Dr. Ginnick is still there as well. This baby in arms now got his liver transplant for BA from a living donor given by his mother standing next to him. So this is a picture of the two together. This child was the 300th at that time in 2016. As I said, we've gone to 400 and 500 since then, but there is long-term survival. That's the beauty of this collage. But is it a cure? And individuals that work in liver transplant would tell you, no, it is not a cure. It is an exchange for a situation which is without recourse to something that we can manage. Chronic disease is what we're giving to. I love this cartoon from Professor Ott from Belgium, where he shows how donation, whether it's cadaveric or living, is giving life to a child, one liver to another. But the question I'm asking is not that. We all know that liver transplant is a success story. It's a clinical standard of care now. But the question I'm asking is, when is transplant not the correct choice? When can we stop doing these 600 liver transplants? And there's a few things that we can help with even after. Biomarkers to predict rejection, treatment pathways to treat rejection, and then, of course, getting rid of the management, the chronic disease portion, which pretty much comes from immunosuppression, getting rid of immunosuppression. So this is the research focus for us right now, looking at liquid biopsies, biomarkers, gene therapy, enzyme replacement therapy, and the last word there was ASBT inhibitors, and I'll come back to that in a second. So liquid biopsies. We were talking last night over dinner about how we all have our harrowing stories as pediatric GI fellows, learning how to do liver biopsies. Thank God we don't have to do that anymore to our trainees. But we would want to stop doing that for children as well, to replace that needle with something we can do off of a non-invasive or at least just a phlebotomy. And to do that, Dr. Imamali, who's a surgeon scientist in our group, she just had a paper in Science Advances where she can use spatiotemporal mapping of inflammatory cells and predict whether it's chronic rejection or acute rejection. I'm not going to go into the details, but certain diseases, all of that laundry list that we saw, I think Naeem talked about PFICs, which is progressive familial intrahepatic cholestasis. It's a basket diagnosis, better defined by the actual genes that change. FIC1 is one such gene. And when you look at surgical biliary diversion instead of transplant, you can get better outcomes with just surgical diversion. I'm not going to go into details of these things, but I'm just mentioning that there are options other than transplant for certain diseases in pediatric liver, in the subset of pediatric liver diseases. If you have an improvement in serum bile acids below 65 after a surgical diversion, you will live more without a transplant. This is a complex biochemistry pathway list, starting with cholesterol, ending up with bile acids. When you have a defect, all these yellow highlights, small boxes, for a reason they're small because I don't want you to read them, is you end up with bile acid synthetic defects. And your liver can be, instead of blue, the color here is red, called serous red, but stains the same collagen fibers, a lot of damage to your liver. You give back oral cholic acid. This was discovered by Dr. Jim Hybe and Dr. Ken Setchell, and you will reverse said liver disease just by giving back oral cholic acid. That is now a FDA-approved therapy. Alagille syndrome, we can talk about maybe at noon conference about the components, but yet another genetic disorder that leads to cholestasis. The ASBT inhibitors, the bile salt reuptake pathway, have been shown to decrease pruritus in children who have Alagille syndrome. And our hope is that it will prevent the need for transplantation in these children as well. Again, FDA approved, EMA approved now for Alagille syndrome. Another group of disorders that we just mentioned, the PFICs, also with these ASBT inhibitors where you do not have reuptake, you just force the bad bile acids to go out through your bottom and you produce more a better milieu of bile acids, in a better pool of physiology of bile acids by pushing the liver to do so, also avoid liver transplantation. So medications, but what about gene therapies? We're talking about specific, at least for 1, 3, and 4 PFIC, integrating gene therapy into the treatment paradigms for these rare disorders, where you can now, like sickle cell is already approved. Maybe tomorrow we will be looking at PFICs having gene therapies as well, potentially through the integration pathway. Wilson disease, a lot of us have heard that. There's a new drug coming on the market for that. It's not approved yet, and I do not have any bias with them, but recruitment for the study is completed. We're hoping to have that come, get approval and come on the market as well. Again, the theme here is trying to avoid transplant. And then going back to the very first slide within this section, where I talked about biliary atresia being the most common or the majority of transplants for children. What about BA? Again, it's probably not one diagnosis, it's a continuum. But again, these ASBT inhibitors have raised their head as a potential mechanism. There's so many studies that are ongoing right now using these bile acid reuptake inhibitors and see if we can change the natural history of biliary atresia and avoid transplantation for these children. So I'm going to stop here and open up for questions, but summarize in 3 broad themes. Prevention. We talked about MASLD or NAFLD or fatty liver disease, whatever the nosology of your choice. My one thing for you to remember before you leave, if nothing else, is, and you have to repeat after me, I'm a lot about alliteration here. If it's sweet and you can pour,
If it's sweet and you can pour,
kick it out the door.
kick out.
The kids get a kick out of this. I used to go through 5, 3, 2, 1, the AAP, 10 different things you're not supposed to do, going back to diet and exercise. Now I say, at least during the first visit, just this one line for diet. As we all know, sugar sweetened beverages have strong data behind them to be avoided. Might as well work on that first. Identification of new drug targets. One's already approved for adults, resmetirom. We'll see what happens going forward with all the others we talked about. Quality, let's improve the care we give for the children that already have the disease if we can't prevent it. Applications of new biomarkers and rejection predictors, and of course, collaboration such as what we can do between our centers. And then beyond transplant. Yes, we can do it. Yes, it's a standard of care, but it'll be nice not to do it. So that's where I will end. Of course, need to thank all the groups that I've been part of. This is Randy back up here. I mentioned him a couple of times. Steve Woods was his mentor. He discovered the effects of insulin. That's me when I was younger. This is Ken Setchell, who I mentioned, the biochemist, who really has changed the world of bile acids for a lot of us. He discovered 8 genetic defects amongst those, that small little cartoon I showed in terms of bile acid synthetic defects. This is my group when I was in Cincinnati, and this is our small group at LA, and I'm happy to answer any questions.
So I have 2 questions. First is, you showed data on bariatric surgery. I think it was like 15-year follow-up and continued weight loss. So a few months ago, NASPGHAN, which is our pediatric GI society, had an online seminar on treatment of obesity and fatty liver disease and so on. And the surgeon spoke at it. And one of the things he said was, of course, like you mentioned, when you have gastric sleeve or Roux-en-Y, GLP-1 levels go up, and probably GIP and others, all the anti-obesity hormones. But he said after 10 years, they go back down to the level they were at, and you see weight gain in people. And this was a surgeon who makes his life doing surgery, kind of arguing a little bit against surgery. So I wonder if you could comment on that.
Yeah, I think.
Just repeat some of the question for the Zoom.
Sure. I'll go back to actually the slide that we're talking about, which Dr. Ingabo was mentioning, that maybe surgery is not 100% going to be maintaining the weight loss that we get initially. And I will say that is pretty much on par with my understanding as well. So here's that graph. You do see down to about 35–40% weight loss, but there is an increase even within the first 5 years. However, people find their set point, and that set point seems to be pretty, again, this is an adult study. There are pediatric data now up to 10 years. The 5-year one from the group that the NIH funded Teen Labs is published, and they have a similar, so the initial success is much more. The stable weight may be a little higher, and there's always going to be exceptions, right? But that don't lose weight or they regain a lot of their weight back. But this is on average what happens.
As the part of me that's a general pediatrician, I mean, we see, these obese kids coming in the clinic for well checks and all that all the time. And, we just, we know that lifestyle changes they're gonna be hard and, there's only gonna work for a small amount that are motivated and most people are not. I mean, it would be easier to get Dr. Ingebo to like getting up early in the morning than it would be to.
I don't know about that.
Yeah, I mean, there's just some things we know are not gonna happen. What would be interesting, is there any way to separate out the rare kid whose liver, or maybe it's not that rare, but the kids whose liver aren't gonna like the
House guests.
molecules there from those that can, because it seems like if we could tease apart that population, there's some kids that are like, yeah, they're heavy, but their liver's not really reacting to it and it's not really worth a fuss. But maybe there's a certain percentage of kids that it really is worth a fuss. And how can a general pediatrician 20 years from now tell apart which type of kid, if it's going to be a high risk or medium risk or low risk?
No, so I'll rephrase the question, summarize the question, which is essentially out of every 5th kid that comes to our clinics that has overweight or obesity, discern the population that is at risk for, say, liver disease or sleep apnea or something or the other. So I think that's where our recommendations, our guidelines come in. The NASPGHAN, the Pediatric GI Society guidelines, which are now being rewritten as we speak, but I'll go with the ones that are published for now, put out an ALT to be measured and alanine aminotransferase to be measured between 9 to 10 years of age. And we said that age was because that's when the endocrinologists want us to measure cholesterol. Cardiologists want to measure cholesterol, insulin, and so forth. So that there's no multiple blood draws happening for the same child. So if the ALT is over 80, there's a high predictive value that their liver is inflamed and or scarring. If you wanted to be more scientific about it, there's a nice paper where you add GGTP or gamma glutamyl transpeptidase to the ALT. And if the GGT is above 30 and your ALT is above 80, there's even higher level of suspicion for significant liver disease. So I would say screen the children, and that's what our guidelines talk about right now. And then when you understand that these children are the ones that have more liver disease, send them to the GI. We can do due diligence to make sure there's no other liver disease other than obesity. And then focus down on, again, we do not have any NASH, MASH approved therapies, pharmaceutical therapies for children. Ozempic and Wegovy are both approved for over 12 if you have diabetes and obesity. So there are some tools in our kit already. Whether or not we should use the ones that are meant for obesity alone or diabetes and obesity for liver disease, that's a different discussion. I don't think so, because we have to prove that subpopulation. There's a preclinical paper we just put out where when we use sema on mice that were on a high fat, high carb diet, their fibrosis got not better, but worse. So I think we need to study these subpopulations before we start throwing all these drugs on every subpopulation at risk.
And you mentioned screening at like 8 or 9 or 10. We screen all of our all our kids that left with the CMP and the lipotap. Is there some reason we should be doing it at 9 rather than 7?
No, I think it's a range. Whenever you're drawing blood, I think 1 year for certain children I don't know if that was sampling error in that biopsy pair that I showed at 10 and 12. Or it was really progression of disease. I have no way of proving. If I had imaging, maybe I could have done that. But I think 1 year these are slow moving trains. You should be fine. You're just doing a screening test for a large population.
Rohit, you talked a little bit about just your comment about GLP-1s right now. It's become such a, just such a hot topic because I mean, you can drive down the street and find 6 people to give you GLP-1s. Probably 6, which are not doctors. But speak a little bit more. I think you hinted on it, right? Or not hinted, but you spoke to it, right? Then what are your concerns about such the broad spectrum utilization without really good monitoring?
So if you look at the way these drugs were approved by the FDA, you have to go by the indications that were studied. They were studied for obesity. They do produce weight loss. As I said, when you eat food, the bolus of food, once it reaches your ileum, is when GLP-1s are secreted from the enteroendocrine cells, the L cells. And again, it's the bile acids that trigger that secretion. The GLP-1 then causes us to think and say, oh, I've had enough, so I'm going to stop. However, the naturally occurring cycle of bile being secreted, GLP-1 being signaled, satiation happening is pretty quick, right? 6 to 7 times a day, we will eat a meal or a snack and we will eat and stop eating. So GLP-1 is supposed to be short acting. What has been done is, and we've known this for 20 years. I mean, my first paper was on GLP-1 when nobody else wanted to study it. Now we've modified, we as in the scientific community, pharmaceutical industry, have modified the GLP-1 backbone to make it long lasting, almost like peg interferon, right? So you can have a subcutaneous injection once a week or an oral pill once a day, and you're suppressing said appetite throughout that week or throughout the 24-hour period of efficacy. When they studied for obesity, it produces the endpoint weight loss. There were no significant safety signals seen. When they studied for diabetes, you have improvement in diabetes. Actually, now there are subsequent papers that have come out about heart disease in adults. And yesterday there was a paper on neurological improvements. So there's a lot of benefits that are
Addictions.
a lot of improvements that have been seen. The caveats are, one, 90% of these studies are in adults. And second, just like we're talking about the 15-year study in bariatric surgery, we don't have 15-year studies in Ozempic or Wegovy yet. So phase 4 monitoring is going to be very critical. And then layered on that are 2 papers specifically for fibrosis. One that I just mentioned, we published in Scientific Reports. I didn't mention the journal about NASH in preclinical models, but there was another paper in the Lancet which looked at adults with NASH on semaglutide, and they too did not see improvement in fibrosis. So why am I harping on fibrosis throughout? Maybe I should have mentioned before, that's what predicts your progression to liver transplant or not. If you see fibrosis at biopsy, at diagnosis for NASH MASH. So long story short, it works for obesity and type 2 diabetes, at least for the studied period. And the safety signals were not strong during that period, so drugs got approved. However, that does not say we should not monitor phase 4 very closely, and there's no data showing that SEMA or any other GLP-1 or GLP plus GIP is specifically good for fibrosis. That's where I pause and I don't want to carte blanche say we should start using.
But
Essentially-
bariatric surgery increases GLP.
Yes, that's the whole mechanism.
So, I mean, it's kind of the same thing. You say the same thing about that, like, we don't know what happens to children who have their GLP-1.
We don't.
So,
We don't.
although we have 20 years of data on.
Bariatric
Ozempic.
surgery.
Well, on Ozempic as well. Is it-
But the different dosing though.
Yeah.
Yeah, and not for under 12s.
Right, right.
Yeah.
Yeah, it's diabetics. adults.
You had said that these, in that a smaller group, the fibrosis actually got worse.
In mice.
In mice, that's
Got
preclinical.
worse
Yeah.
inside in your studies,
Yeah.
right?
So all I'm saying is that, yes, these may, I mean, PepsiCo and Frito-Lay stock went
You're
down.
not getting sponsored.
Those companies are shaking in their boots too. If we're all going to live longer and all going to be leaner,
And not drinking Coke.
yeah. But thank you for all your attention and questions. Oh, you have
I had a question. Oh,
somebody else in the back too? No, okay.
so my question is, who are in the pediatric world, who are the experts in treating obesity? And the reason I'm asking this question is I feel like a third of what I do is nutrition. And ever since I was a fellow, I assumed obesity was part of pediatric GI. I realize endocrine has diabetics with obesity, but I actually especially years ago when insurance companies weren't so strict, I got referrals just for obesity. And I still get referrals, these that don't have elevated LFTs, they just have obesity. Okay, so I kind of assumed we were the experts, and I felt like I quote treated it for decades with, the data is so clear that diet and exercise just don't really work. Very small percentage, like, Dr. correctly said. So then we had sort of this thing in our department, and apparently not all pediatric GI doctors think that we are the obesity experts. So my question to you is, what do you think? Who do you send, who does a pediatrician send an obese child to?
I think my personal opinion is that depends on your focus. So my focus was steatohepatitis. If a child came to me without the itis, if there was no ALT elevation, and it was a child who had more than 95th percentile BMI, I will see that child once and send them back to the healthy weight management clinic, or to endocrinology if their A1C was high, or to pulmonology if they had sleep apnea symptoms, but I would not continue to follow them. My partner, Stavros Anthakos, back in Cincinnati, she and I founded one of the very first fatty liver clinics in the country back in 2007. She is also a pediatric gastroenterologist like I am, like Ashish is, but she is also obesity certified, board certified. She has an interest in treating the child who has no ALT elevation, but has obesity in isolation. She chooses to treat and stay with them all throughout. I think it's an individual choice. I'm more of a hepatocyte. She's more of an enterocyte. I don't know. It's an individual choice.
I'm gonna jump in. Just say that you get all.
Mm-hmm.
I really think it's general genetics, but I think GI and endocrinology to have something there. We could do one thing and have a how.
For a subset, that's what we did in Cincinnati. We do not have such a MDC in LA, but we did have an MDC. We had actually a circular set of rooms. All the specialists used to sit in the well, and one by one, we would just pollinate all the different rooms.
What percentage of that?
Oh, that's
Majority.
There are three specialists seeing the same. Child. All three specialists want them to lose weight, and the patient.
advanced care, but I didn't
And you order this, insurance company won't pay for it.
Now they will pay for the surgery, maybe. Well, thank you, everyone. It's a pleasure.